First, we have Nancy Joyner. Nancy is a nationally recognized consultant, speaker, educator, and author. She is a self-employed palliative care clinical nurse specialist, and she's gained intensive experience in serious illness, frailty, and the end of life over 40 years of nursing, with 14 years as an advanced practice nurse in palliative care across the lifespan, from neonatal care to the elderly. And I will just kind of keep these brief. If you guys kind of want to add anything else on, you can. Dr. John Berg, has been a rural family physician in Northwood, North Dakota since 1985. From that time until 2011, he practiced the full range of that calling with clinic, hospital, and emergency room activity. Since 2011, he has primarily been involved in long-term care medicine in 5 rural nursing homes. And finally, Dr. Jacque Gray is from Oklahoma and is of Choctaw and Cherokee descent. She's worked with tribes throughout the Indian country for more than 35 years in the area of health, education, counseling, and program development. She also has experience in policy work and advocacy through testimony on in Congress on suicide of American Indian youth, funding for Indian Health Service, addressing elder abuse in Indian country, addressing mental health and aging, serving on the Health and Human Services Secretary Advisory Committee for interdisciplinary community-based linkages, and other health disparity related issues. So like I said, if you guys kind of want to chime in, add anything else extra, I could probably go on for about an hour with everything I have here. So without further ado, we are ready to get started.
We definitely, you know, it's what matters beyond what we're going to be talking about, definitely.
Objectives, what we're going to go through here, along with other points, I'm sure. First off, defining the term advanced care planning and identifying where POLST, P-O-L-S-T, fits in that. POLST is Physician Orders for Life-Sustaining Treatment. Secondly, we'll talk about why what matters as a conversation matters the most. What matters is part of the 4 M's in creating an age-friendly healthcare system. It's a movement that's going on across the United States, and Dr. Jurevich is instrumental in that in our area, getting that spread around our region. And what matters is one of the 4 M's related to geriatric care. And we'll talk about why that probably is the most important of the 4 M's. And lastly, talking about cultural factors that impact what matters and the conversations that follow.
So we're going to delve into what is advanced care planning. There's so many misconceptions about it. People think right away for the healthcare directive, and there's more to it. Next slide, please. This is from Respecting Choices, the Gunderson Health, that states that it's a person-centered ongoing process of communication that facilitates individuals' understanding, reflection, and discussion of goals, values, and preferences for future healthcare decisions. It's not just about disease, and it's not just about the piece of paper. Next slide, please. And we need to look at it as a whole person. You know, we often think of physical, as I said, like the disease, but we as humans have so much more integrity to who we are. So the wholeness needs to be evaluated each time that we're looking at an individual and holding some of these conversations that need to occur. And we're going to get into specifics about that. Next slide, please.
This is, yeah.
Jackie?
Well, advanced care planning is not an easy talk to have. When we look at working with individuals and families, a lot of times they don't want to talk about death. And within some cultures and ethnicities, especially I know with natives, certain tribes, to bring up death is to call that spirit of death upon that person. Just like to talk about cancer is to call that spirit of cancer upon the person. So you have to work within the different cultures as to how is an appropriate way of getting into those conversations.
In my practice, which has been based in a small town in eastern rural North Dakota, it isn't so much cultural differences because it's pretty much Northern European agricultural immigrants that have settled and the primary people staying there. The differences that I see are not as much related to culture, since it's so homogenous where I am, but it's more related to the families, their own beliefs and experiences and what they've been through. And sometimes their religious beliefs as well do impact this discussion. Next slide.
So when we're looking at delivery of person-centered care, when you're talking about older adults, they experience a lot of transitions near end of life. It may be transition from their own home to having a caregiver, to being in someone else's home or a long-term care facility or assisted living. And there are more opportunities for hospitalizations and higher rates of preventable hospitalizations. So we want to look at how do we increase demand for family caregiving, look at personal care, household tasks, medication management, all of those different things that have to happen for that person to be able to age in place or in a more familiar environment, and looking at that burden on the healthcare system. So we want to delay as much as possible a referral to palliative care and access to those long-term care facilities. Next slide, please.
Talking about this from the provider perspective in communicating these things, this slide gives us 3 points about that. Before I go into those, I just want to say that right now, most of our advanced care planning happens with people in their later middle age or early old age. Very commonly, it doesn't happen until people are quite frail and in the nursing home, unfortunately. And we're hoping that presentations like this are going to increase the time spent in our healthcare system, finding out what people want and going through that advanced care process. And it is quite variable from patient to patient, family to family. You've got not only your genetic variability in each person has their own set of genes, but you've got life experience in disease and trauma. You've got life choices in diet, exercise, tobacco, and alcohol. You've got accumulated beliefs and family beliefs that happen around people. So a main hallmark in geriatrics is the variability that we've got. That's why conversations are so important. We need to talk with people and find out who they are and what is important. This slide talks about most people near the end of life are unable to make their own decisions. That's a very important thing to realize. Hopefully, before you get to that point, you've had a discussion with those who will be making those decisions. The children in the family, spouse, other loved one, trusted friend, someone who will know what it is your choices would likely be. And then talking about alleviation of pain and suffering, and that we need some medical orders that provide for that. Later on, Nancy has a slide in here talking about comfort care always, not only. That's important whether we're doing curative care or palliative care. And then frequently checking back with conversations, talking again and revisiting, updating patients and families on as a process changes. Quite frequently, when an older person is undergoing medical care, they may respond or they may not. If their clinical situation is getting steadily worse, it's time to reconsider decisions we have made. Next slide.
So as Dr. Berg said, this is an ongoing process from the time that someone is healthy to the point that we're allowing natural death. It's really to maintain and maximize their health and independence, their quality of life, who they are as an individual. But we have to be prepared that chronic disease will step in, that it becomes more advanced at that point, and then more multiple comorbidities as we're living longer with more diseases. So it's important, including frailty, that we don't overlook those components of it, and to really look at it as an ongoing process that does not stop, doesn't just come at one point. As Dr. Berg said, we need to have several conversations along the way. Next slide, please. Where did we come with advanced care planning? The Patient Self-Determination Act was finally kind of the root of what happened back in the 1990s. And it really said that everybody had a right to choice, you know, with what kind of decisions that they would want as far as their goals of care. There are many cases that went on along that time with Karen Ann Quinlan and Nancy Cruzan, et cetera, that people were, where do we go? They were floundering. How long? Because now we have all this technology that can keep people alive. And is this the quality of life and how they want to be kept alive? So that was really the beginning of that point in time. Then the Matters of Life and Death saw that there needed to have more education out there, the awareness and education for implementation. From there, then the POLST was then adapted, which we'll be talking about in just a few minutes. And then we still found, though, that the advanced care planning became still an issue for people. Next slide, please. Through our state, we looked at advanced care planning, that it wasn't just that piece of form, that we needed much more conversations with that. And so that between the POLST and some of the other things that we witnessed, that we need to have a different way, a different tool and a way of spreading that. So through the North Dakota Medical Association, they said, and through their ethics committee specifically, they said, we need to endorse this. We need to move it forward. And so we became the North Dakota Advanced Care Planning Initiative, and then eventually became the Honoring Choices North Dakota component of it, which we still have today. And I encourage people to consider joining us. There's no cost to it. It is all voluntary and charitable in that respect. And since April of 2015, we have been active and have a great website, and it's included in your resources.
Okay, are you guys seeing the results?
Yeah, yeah. 2/3 of the people had seen the form. And we wanted question 3 as well, if we can.
There you go.
Okay.
There you go.
Okay.
Okay.
Okay. Next slide, if we could. What is POLST? POLST is one tool to use in advanced care planning. Advanced care planning is the umbrella term. It's the big circle, and POLST is one circle, or actually a tool to accomplish some of the goals within that. The next slide will show that a little better, but let's pause right here. This slide shows us a picture of the North Dakota POLST form. It's got that light green border, and it is printing on both sides. The back side gives an explanation of most of these sections to fill out. There is available CME, I think, through the Honoring Choices website, that you could learn more about going over with your clients, residents, patients on this form and how it can be filled out. It is one way to help go through a conversation, and not only go through it, but arrive at some choices that can then be turned into actual medical orders. It should be ideally sent with the patient wherever the patient goes. My practice is nursing home patients, and we have these forms filled out. I can't say 100%, but it's very close for the residents in the facilities in which I work. And that form needs to go with them. We hope it's being acknowledged, and it guides care wherever they end up. Sometimes that seems to work, not all the time. How about the next slide? Here, this is advanced care planning continuum, the big circle. Now, ideally, it would actually start as soon as you're adult, age 18. I would say it's probably pretty hard to get an 18-year-old to acknowledge that death can happen. There will be those people with unusual circumstances, diseases, trauma that occur that bring death very close and near. Thankfully, I have not had to deal with any of those. Most of my work is with patients who are in the upper ages of life, but completing an advanced directive. An advanced directive, we'll talk about that a little further down here. In fact, the next slide, updating that periodically, and then going over whenever we hit serious illness, bump in the road, something's changing, check back, is this still appropriate? Is this still what we want? This slide talks about physician orders for life-sustaining treatment, POLST form, compared to a healthcare directive. A healthcare directive is a wise thing for anyone to have. All of those listening, I encourage you to download forms, again, which would be available on the Honoring Choices website. Go through that with your significant others, family members, the people who will be there when you're sick. They need to know, this is what I want, this is the way I would like things decided. It's a very important document. POLST, however, is for those people at the end of life. Would you be surprised test, would you be surprised if this person were to die within 1 to 2 years? If so, POLST probably isn't a necessary thing. If you really wouldn't, if they've got enough age and disease burden, then it's wise to get that POLST filled out. And again, POLST is a series of questions, starting first with, do we want CPR in life, and going through intensity of medical care, and then questions on feeding tubes. Those are some critical issues that may well come up as options in encountering serious illness. And one goes through that, fills it out, the patient signs it, or their person speaking for them, their power of attorney in whatever way, and the physician or medical provider signs it as well. It then becomes actual medical orders that EMS personnel will obey that, will go along with those orders. If the person doesn't want CPR and they've been called to that home, and hopefully the POLST form will be available to them, they would not perform CPR and that type of thing. It's POLST is a tool that we use to make sure that the outcome of those conversations actually gets done, that what the patient has wanted will actually be completed. And then the next slide.
So why does what matters matter the most? Next slide. When we look at what matters and why it matters the most, with older adults, it's important for them to be more engaged and to feel listened to. They want to know that those providers that are working with them actually understand what their preferences are. And it tends to avoid that unwanted treatment while they receive that treatment that they do want. And here, as Dr. Berg mentioned earlier, is where comfort care is always provided, not just only provided.
Some of the statistics from studying advanced care planning and working through this process show some real benefits. Inpatient admissions, which frequently are optional in my frail elderly population in the nursing home. Lots of things we can treat sensibly in the nursing home, and patients and families will decide, you know, looking at what mom wants, what's ahead in life for her, we don't think we want her to have to be in a hospital where she doesn't know the providers, where it's farther from home. We're just going to take our chances here in the nursing home. It reduces inpatient hospitalization up to 54% and reduces intensive care stays up to 80%. Intensive care is a marvelous place if you happen to be seriously ill, younger, and previously in good health, living independently. It is a living nightmare if you happen to be a frail elderly person, and you really don't want to end up there. That happens when patients and families don't know what their options are and what the likelihood of success of those various options are.
It's also important for everyone in that patient's life to be on board with what their wishes are and what's going on. We want everyone to be on the same page, because you don't want that patient to be at a point that they can't speak for themselves, and there tends to be fighting amongst all those others in their lives as to what's the best thing for them. It also helps to improve those relationships as that elder approaches end of life. And that is actually the basis for everything else that you do, is having those relationships and that everybody being on the same page. Next slide, please.
Okay. This is, okay, yes. Hippocrates was quite a guy. I wish I knew more about him, but here, more than 2,000 years ago, he was spot on talking about person-centered care. It's more important to know what sort of person has a disease than to know what sort of disease a person has. Next slide.
This becomes a point, you know, that we need to really focus, exactly like Dr. Berg said, on patient perspective. You know, that we need to look at who that individual is, you know, what matters most to them. Next slide, please. One of the things that we can do is change our wording, because so often we'll say, what's the matter? But it's more important to say, what matters to you? We might have our own agenda, but believe me, it quickly changes when you really ask who that person is. Changing it to focus truly on who they are, to let them separate us as staff, but bring us together as a whole person on focusing on who they are, and let them be the team leader for where we are with that. We change our expectations that way as well, that we're not just focusing on that disease of congestive heart failure or COPD or diabetes or hypertension, and now even in the COVID world. So, you know, that we have all these things that are going along with that, so that we are really collaborating and working towards the same thing, as Jackie just said, that we all get on the same page. Next slide, please.
And as we were talking about this, I related a story that I'll tell you about now, that an elder friend of mine was telling me about his father. And we're going to call this native elder Roy. Roy was 88 years old. He had diabetes and hypertension. And he was admitted to a nursing home after he was hospitalized after he had a fall. And he kept telling the staff he wanted to go home. Well, one day, my friend, his son was there, and his father was telling him, he says, you know, I start leaning to the right, and all of a sudden here comes somebody from the staff, and they straighten me up and put pillows on the right side of me so that I can't go in that direction. And he said, and then I start leaning to the left, and here they come right quick and stack the pillows up on that side so to hold me upright and everything. And he says, you know, you can't even fart in this place. I want to go home. And so what mattered most to Roy was to be comfortable to do what he felt like he needed to do. And this friend of mine was telling me that the next day his mother pulled up in the car and kidnapped Roy and took him home. And he lived several more years comfortably at home after that. But he wasn't comfortable because they weren't taking into consideration and listening to Roy as to what he wanted. Next slide, please.
So it's really important to, nobody chose anything related to medical appointments. If I had put down medical conversations, we probably wouldn't see that. And look at how we're even getting away from the whole COVID idea. Family is most important. And so often that's what we hear. Such an important thing of who we are. Next slide, please. Jacque, do you want to start?
Well, who do you want involved in your care? What is important? You know, for some families, they want to make all their decisions. The individual wants to make them all for themselves. For others, they want to include their family, as we saw in the poll, or lots of other individuals that may be important to them in making that decision. The other thing is ceremonies. I know for natives, things like being able to smudge at the bedside and things like that, having end-of-life ceremonies, and those things to help the passing and moving on to the next phase of their lives. Those are all important. When we talk about what's going forward, who do you want involved? What kinds of things around your beliefs and ceremonies and things like that do you want involved? And what other people?
Yeah.
Go ahead, John.
I just, again, Patient Voices is the title here. And if we don't hear patient voices, if we don't ask the questions, we don't get that input. And so to me as a medical provider, it just says, have those conversations, find out the answers to these questions, find out who these people are. I almost always, in my first encounter with a nursing home patient new to a facility, I always want to know, where did you grow up? Are you married? Are you still married? Is your spouse living? Do you have children? What did you do? What did your spouse do? To find out what kind of a life they've lived and help me understand the things they likely are going to have an interest in and the likely way things are going to be going for them. And it gives a basis not only to getting to know that person better, but then in the future, being able to pull together families so that we can all get the best care, the care that patient really wants completed.
So the one thing, I add 3 little words so frequently when I'm asking questions: help me understand. It gives so much meaning to that person that we're having dialogue, that they're of importance, that they can share what they want to share and have that dialogue open so much. Just those 3 little words help so much with just help me understand. And the last bullet here with how much technology we can offer more and more and more, but is that still what they want? Do they know what the risks, benefits, burdens, and expected outcomes are? Do they have that information? It's so often that it isn't there. Next slide, please.
So in summary, all those things we want to know, they want to be informed as to what's going on by the staff that are helping to take care of them. They want to, get that staff prepared to understand what it is to listen to a person, what kinds of things you need to pay attention to, how to have their wishes honored, and how to best communicate that. And until you've had some time to think about some of those choices, it's hard to know what your choices are. The other thing is how you're being treated as far as your age is concerned. What may be done for an 18-year-old may be different for an 85-year-old. But the other thing is, as you get older, you don't want to be treated like an infant and talked to as, in baby language, we might say. So being respected for your age, but at the same time, considering those things that are relevant to you, and to see the patient as a person, not as their illness. They aren't the diabetic in the next room or the amputee or whatever that is. They're that person that's dealing with that challenge in their life. And they want to be with people their own age. We have senior centers a lot of places, and that's where you see people congregate because they have shared experiences that they can talk about. They want to be with those people their own age, and they want to know that there's going to be someone there that actually knows them. Not in the hospital any longer than they have to be. They want to age in place. They want to live in their own homes as long as they can. And then not many times with natives, because there are less than 20 long-term care facilities on reservations nationwide. To be sent to a nursing home is being sent away to die, because it's removing family, it's removing friends, it's removing culture from their lives, and those things are very important. And then they want a friendly and caring staff, again, that will treat them as a person, not as an illness. Any other comments by my co-presenters at this point? Okay, next slide, please.
Clinicians' responsibilities in all of this, what are we to do? And as I looked at this and thought about it, a basic summary would be 4 points. First off, it's the clinician's responsibility to open that discussion. We've said before, families and patients very often don't want to talk about death and dying. They'd rather talk about almost anything else, including their hemorrhoids. So the clinician needs to open that discussion. Then it's a matter of educating about the choices that we've got. Well, this is your diagnosis. This is what you've got. This is the other complicating factors for you. And here's the different things we could try, as well as laying out those options, then saying, and this is what I think would be the likely outcome of each of those options. And then we pull it together with the patient, with the significant others, family members, and find a consensus. Then that clinician needs to make sure that consensus is recorded in the electronic record and transmitted to all of the consultants so that all of us know what this patient and this family want in these situations. That's a big set of responsibilities, and that's the ideal situation. I wish it happened all the time. Next slide. This is a series of opening questions, all of which would fall under Nancy's 3 words: help me understand. Basically, that's what we're asking when we're opening that discussion. Who do you want included in this conversation? What should I know about you that may not be in your medical record? And I'll tell you, there's a lot we need to know on a person-to-person basis so that we can know who these people are. What does a good day look for you when you're in the process of coming closer to death? Or if you're talking to somebody before a procedure, whether it's cardiac, abdominal, orthopedic, what do you want to be doing 6 months from now that you're not able to do now? Or as we're getting ready for discharge, we're wrapping things up. Is there anything you're worried or concerned about as we look at going home? Or what will success look like to you after this surgery? What do we accomplish? Next slide. And
Jackie wanted to add something. Jackie, did you want to add something?
I just wanted to add, you know, who is important in helping you stay in your home? Who are those people around you that are important for that to happen?
usually that's going to be children, friends, neighbors, spouse, that people, the same group that hopefully is there at the table participating or at least hearing the discussion. And this is just, I know when I entered training, we were just beginning to talk about patient-centered care, open-ended questions. It's so easy as a physician to ask some questions, think we know who this person is, and then pretty much lay out what we think would be best for them. If we're really going to be patient guided, we want to go through those set of questions. And we have coming up here later some a discussion guide that will help with that. But if we're patient guided, we're making sure that this is the patient's list of priorities, not what we think they would need. Next slide. And what to discuss. Yeah. Again, a series of questions. Let me see if there's any here that, what would make tomorrow a really great day for you? I need to ask that more in my nursing home rounds, both because it's really surprising to find out sometimes, but also because there's usually a nurse with me or a nurse's aide nearby, and it would be good for them to hear as well.
Well, and I also think, how do you learn best? For a lot of natives, it's an oral tradition. So hearing stories as opposed to reading stories is really important. So being able to have that oral presentation of information is very different for them than being given a whole stack of papers to read.
Yeah, or go to this website and fill out this questionnaire. Yeah.
Or a brochure.
Yeah, yeah.
And then to add, if they have any deficits as far as hearing, do they hear better on one side or the other? Are we talking too loud, too soft, too fast? I mean, there are all these other ones on how they learn best with that. So getting feedback, have them, what did you understand? Help me understand. Now, what do you understand? And going back and forth with that dialogue always helps quite a bit too.
And what their worries are. What is it about any treatment that you need or different options that we're talking about that worries you the most, so that we can start talking about those issues and talk about options related to that.
Yeah.
Goals is another one we're going to be talking about in just a couple minutes here, but it's important to find out, again, from their perspective, not just from our own perspective, what's there.
And a lot of times, all of these are couched as questions, but sometimes it makes a lot more sense, rather than to ask a question, to make it a statement, as in, tell me a little bit about whatever it is, that they don't feel like that they're at an inquisition of some type.
That it's more of a dialogue, exactly like
Right.
that.
Yeah. Nice idea. Nice idea.
Next slide. So when we talk about culturally appropriate what matters conversations, you need to learn some things about the culture and being able to get to what is the term that they prefer for their cultural identity. Is it American Indian? Is it Native? Is it Lakota? Is it Oglala? You know, what do they prefer to be called by? And knowing how formal they expect you to be when you address them. When you're talking about Asians, they really revere those that are older, and you're much more formal with that than you might be with some other groups. Determining preferred language. Do you need an interpreter? What's their first language? What kinds of materials? Things like that. And being respectful even with your nonverbal communication. I know just even, you know, in greeting someone when you come into the room, I've had people tell me of older, elderly men, Native men, that the physician comes in and calls them chief. Well, that's very disrespectful. That's not who they are. So being aware of those things and being respectful. I know another situation that I went to Mayo for some treatment, and I said, they were asking me where I worked, and I said the med school. And the resident that was interviewing me said, "Oh, are you a secretary?" And my son leaned the opposite way because he thought I was going to haul off and hit the guy. But, you know, being respectful, don't just make assumptions as to how someone wants to be addressed. That creates that distrust, and you really need to have a good trusting relationship in working with the patients and their histories and things like that. And when you're thinking in terms of history, thinking, you know, be careful in gathering that information. I know I was told about another man that was hospitalized, and he was having trouble communicating, and two orderlies came in to give him an enema, and he was fighting and screaming, and they were re-traumatizing him. This was a man who had been sexually abused as a child in the boarding schools. So the hospital was more of another institution, and here were people holding him down and violating him again. And so it was re-traumatizing him. So really needing to be gentle and gathering that information and sensitive to those types of experiences that they may have had. Recognize that their health beliefs and alternative therapies, are they wanting to include a medicine person or some type of traditional healer involved with their care, and making sure that that's addressed and discussed as well. And considering all those decision-making factors and the individual's autonomy in making those decisions, but also maybe it's a matter of their autonomy in including a group of others in making those decisions. Next slide.
In this slide, we're talking about the goal of what we're doing here, of the goals of this discussion. And in the next slide as well, we'll have an example of a guided checklist that brings us through that. But this series of questions does get to that. What is the one thing about your healthcare that you most want to focus on, that you can do so that you can do things more often or more easily? And what are your most important goals now as you think about the future of your health? What concerns you most when you think about your health and healthcare in the future? What are your fears for yourself and your family? Am I going to become dependent on family? Can I still live on my own? What are your most important goals if your health gets worse from where we are today? And what things about your healthcare do you think aren't helping you, that you find too bothersome or difficult? Is there anyone else who should be part of this conversation? These are good ways to get at the goals of advanced care planning in those conversations. Next slide. This is a picture of the first page of what's called the Serious Illness Conversation Guide, developed in, I think, 2014 by a group called Ariadne Labs. It's based in Boston. It was founded and headed by a man named Atul Gawande. You may have heard of that book, Being Mortal. If you haven't, I would highly recommend that book to help look into these conversations. The whole book is a conversation with various people, both the physician's father as well as others, about what's important as I go through aging and end of life. The work in Ariadne Labs, they work off checklists, and this is one checklist to make sure that we get what we need. You can Google Serious Illness Conversation Guide. It'll get you to a 4-page printout of the form, but you should really do more study and look into some actual training, which is provided through the Ariadne Labs and probably is available online. I can't say that. If this whole concept is new to you, I would highly recommend printing out something like this, having it available as you're going through a discussion. And there's a number of other conversation guides that are available, sometimes for specific illnesses and sometimes for specific groups of patients. Next slide. Again, that Hippocrates fellow, I've realized the wisdom of this in my long-term care practice. To do nothing is also a good remedy. And more often than not, that proves itself true, at least in my patient population. Next slide. So, conclusions. Advanced care planning is the term for the whole process. Conversations about what matters are what needs to be happening, illuminated by what we know of who this person is at this point and what our special knowledge in medicine tells us about these are the things that are likely to be helpful, as long as I know what your values are. We talked about the POLST form, a tool that's particularly helpful in ensuring that that patient's wishes are carried out as medical orders toward the end of life. And yeah, what matters conversations give the healthcare team that roadmap. If we don't have the conversation, we can't have the roadmap, and then it becomes about what we decide is best, or what we assume is best. And then lastly, that there are cultural factors to consider in these what matter conversations. Dr. Gray, Nancy, anything else?
I just, in this day and age with everything that's been going on with racism and everything, the implicit bias, and I'm glad that Jacque, you brought up some of those things, not only related to ethnicity, but age, part of the country we live on, you know, all these other things that we must consider when we're talking cultural factors. That, John, you brought up, you know, the people that are in your culture from the Midwest, you know, the European background, you know, the whole component of it. So that spirituality, please look at the whole person, you know, with all those different dimensions that we look at when we're having some of these conversations.
To cure sometimes, to treat often, to comfort always. those are good words to close on. And then certainly we're available for questions.
So can I jump in? I just want to thank John, Nancy, and Jackie for doing such an outstanding job in presenting one of the 4 M's, really in the trenches perspective for sure. And also, just to remind everybody that the intention or the goal of Age-Friendly is to apply the geriatric 4 M's with every patient encounter. So if you have the conversation of what matters, it has to be repeatedly brought up. Are there any changes, anything new? Is there anything you would like to discuss? So to get certification in Age-Friendly, one has to apply the geriatric 4 M's at every patient encounter. So the what matters is, you know, may not be a long conversation as the initial one, but at least, you know, to touch base and update and see if there's any new changes. So I would just add that to the transformation of primary care towards Age-Friendly.